الشيء الجميل إن هي طالبة في كلية طب المنصورة في السنة الخامسة، وستقدم هذا البحث الذي تم عمله في مركز البحوث الطبية التجريبية في كلية طب المنصورة عن pancreatic injury induced by renal ischemia, reperfusion injury, possible role of oxidative stress. اتفضلي يا آية.
بسم الله الرحمن الرحيم. My name is Aya Ahmad Abdel Khabir, 5th year medical student, and I will talk about pancreatic injury induced by renal ischemia, reperfusion injury, possible role of oxidative stress. Firstly, what is the ischemia reperfusion injury? Ischemia reperfusion injury is a complex phenomenon that induces damage through a biphasic process, ischemia and reperfusion. Ischemia deprives tissue of energy, which is essential for maintenance of hemostasis and ionic gradient that lead to cellular dysfunction and death. Reperfusion exacerbates damage through stimulation of inflammatory reaction. This leads to accumulation of reactive oxygen species, endothelial factor, interleukin, and cytokines. So ischemia reperfusion injury is due to imbalance between the production of reactive oxygen species and antioxidant capacity. This phenomena is known as oxidative stress. The application of this study in practical is that injury that happened during the renal operation, such as nephrectomy and renal transplantation. So, recent study demonstrated the remote effect of renal ischemia reperfusion injury on some organs, such as liver, brain, and lung. But in our study, we investigated the effect of renal ischemia reperfusion injury on function, histology, and oxidative stress of the pancreas. This figure illustrates the oxidative stress. Normally, there is equilibrium between antioxidant and reactive oxygen species. Oxidative stress occur due to either excess reactive oxygen species or depletion of antioxidant or both. So the aim of our work is to investigate the impact of renal ischemia reperfusion injury on pancreatic function and histology. This is the experimental design we used in our study. We used 24 male Sproge-Dowley rats. They are divided into two equal groups, a sham group and a control group. The sham group rat underwent all surgical procedures except renal ischemia, and the control group rat underwent bilateral renal ischemia for 45 minutes by clamping of the renal pedicle by the surgical bulldogs. Each of those groups is subdivided into two equal subgroups. A group which is sacrificed after 2 hours and another group which is sacrificed after 7 days. The investigation we made were renal function tests including serum creatinine and blood urea nitrogen, pancreatic function tests including serum amylase and serum lipase and insulin, and fasting blood glucose. These values are measured at 2 hours, 1 day, 3 days, and 7 days after ischemia. And we found that serum creatinine and serum blood urea nitrogen show significant increase in control group after 2 hours, 1 day, and 3 days, and they are highlighted in the schedule. Serum amylase and serum lipase show significant increase in control group at day 1 and day 3. And this reveal or denote the damage that occur in the exocrine part of the pancreas. The cause of hyperamyloidemia and hyperlipidemia is due to the reactive oxygen species cause damage of the exocrine part of the pancreas, the endothelium of the exocrine part of the pancreas. Fasting insulin and fasting blood glucose, fasting insulin show significant decrease in control group at day 1 after ischemia. And fasting blood glucose shows no significant difference between sham group and control group at different periods of follow-up. This finding suggested that pancreatic injury induced by renal ischemia reperfusion injury is not significant to affect the endocrine function of pancreas or glucose hemostasis, and I think that further studies are needed to assess function of beta cell and its histology in such cases. After formalin fixation and dehydration, paraffin-embedded pancreatic section were stained by hematoxin and eosin. And the results were: weight of pancreas was show significant increase in control group after 7 days of ischemia. Edema, leukocytic infiltration, and vacuolization show significant increase in control group at 2 hours after ischemia at the end of the experiment. And the pancreatic necrosis was present only in control group at 2 hours after ischemia, but no pancreatic hemorrhage, and this denotes that there is acute inflammation of the pancreas. This is the histopathological scoring we use in our project. It denotes edema, leukocytic infiltration, vacuolization, hemorrhage, and necrosis, and it is graded from 0 to 3, and I will leave it for a few seconds for you to review. Before we know the pathology of the pancreas that occur in the pancreas, we must know firstly the histology of the pancreas. Normal pancreas is formed of a group of acinar cells. Groups of acinar cells form alveoli. These tubules are separated from each other by a thin layer of interstitial tissue. But the pathology which occurs is edema that expands interstitial tissue and separates small and big. On higher magnification, there is a pancreatic acid vacuolization as seen in figure A, which appears as holes, interstitial hole in the acinar cell, as shown in figure B. And the edema was also present. Here there is a line forming in which is a pyramid unit. As a pyramid unit. Here we have group acinar cell, which are mostly unnucleated cells. For estimation of nuclear oxidation and antioxidant enzyme, we use malondialdehyde, catalase, and reduced glutathione. The results were: malondialdehyde shows significant increase in pancreatic tissue of control group after only 2 hours, but no significant changes after 7 days. Catalase level was significantly high after 2 hours control group, after 2 hours and 7 days. And but reduced glutathione was significantly low in control group at 2 hours, but not at 7 days. From this project, we conclude that 45 million bilateral renal ischemia caused terminal change in pancreatic exocrine function and morphology, as well as enhanced oxidative stress and inflammatory state in pancreas. So, care should be taken to protect other organs such as pancreas removed from ischemia reperfusion site, especially during renal surgery. I would like to give a special thanks to the team that worked on the project, including my colleague Amani Al-Zahra, Dr. Abdelaziz Seen, Dr. Muhammad Hok, Dr. Yasmin Shaisha, Dr. Azim Mayouni, Dr. Sylvia Ashwani. And I would like to give a special acknowledgement to the Mansoura Experimental Research Center that gave us the validated chance to perform the project. And the doctor who worked on the center.
شكرا يا آية على البحث الجميل دون، وده شيء عظيم ان طالبة في سنة 5 تشارك في بحث زي ده. لو في حد عنده اي سؤال للطالبة فليتفضل. شكرا يا آية.
Continue with Dr. Ayman Sabri Abdel Badia from the Egyptian Fellowship of Nephrology from Mansoura University, as far as I know, and continue on immunological dysfunction in chronic kidney disease. Please come.
CKD is associated with alteration in two major branches of the immune system, innate immunity and adaptive immunity. Alteration of immune system consists of alteration of innate immunity, which consists of alteration of secreted pattern recognition receptor, high mannose binding lectin level pre-transplantation associated with worse graft survival. On the other hand, low mannose binding lectin level associated with increased mortality. Alteration of endocytic pattern recognition receptor, expression of two major macrophage scavenger receptors increased in end-stage renal disease due to chronic stimulation induced by inflammatory process or by oxidative stress. Alteration of signaling pattern recognition receptor, bactericidal effects of neutrophils reduced in hemodialysis patients compared with controlled subjects. Alteration of adaptive immunity. T helper 1 cells produce several pro-inflammatory cytokines and activate macrophages and neutrophils, while T helper 2 cells are involved in promoting humoral immunity. So the balance between T helper 1 and T helper 2 is very important. Moreover, it has been suggested that one of the major causes of this disturbance is an increased susceptibility of death of B cells by apoptosis. Alteration of toll-like receptor, uremia decreases antigen-presenting cells and macrophages by alteration in co-stimulatory molecules CD80 and CD86 that regulated by toll-like receptors. It seems apparently that it is disorder in toll-like receptor expression and or activity that causes the impairment of functions of antigen-presenting cells. Causes of immune dysfunction in CKD: uromic toxins-related factors, dialysis-related factors, vitamin D deficiency-related factors, and others as volume overload. What is the characteristics of immune dysfunction? Immune dysfunction in CKD characterized by immune activation which lead to inflammation and immune suppressions which lead to infection. Both inflammation and infection lead to cardiovascular disease. The interaction between kidney failure and the cardiovascular system appears to be largely mediated by immune system, which recognize the uremic states as a continuous aggressions to cells and tissues. Vascular changes in end-stage renal disease characterized by atherosclerosis through leukocyte interaction with vascular endothelium during inflammation by selectin-mediated leukocyte rolling, mild adhesion mediated by adhesion molecules such as vascular adhesion molecule 1 and intercellular adhesion molecule 1, and firm adhesion mediated by chemokines and interleukin 8. The endothelial aggressions by uremic toxins lead to modification in the endothelial cell phenotype and to endothelial dysfunction, with secretion of many pro-inflammatory molecules such as tumor necrosis factor and CRP. Myocardial changes are largely mediated by the immune system and characterized by increased myocardial fiber mass, interstitial fibrosis, myocardial fibrosis, cardiomyocytes hypertrophy, and thickening of intramural arteries and arterioles. The other aspect of the coin is infection. According to United States Renal Data System, infection is a common cause of hospitalization in patients with end-stage renal disease. Bacterial, viral, and fungal infection contribute to the high rates of hospitalization and mortality in patients with end-stage renal disease. Epidemiology of infection. Admission rates are 4 times greater in CKD population than in non-CKD population, but almost 10 times greater in the dialysis population than in the non-CKD population. Moreover, the first year incidence of infection-related hospitalization was 32% for those who received hemodialysis and 24% for those who received peritoneal dialysis. Also, the 3-year incidence exceeds 50% in both groups. In this study, shows peritoneal dialysis and hemodialysis patients had similar infection rates overall, but type of infection and risk over time varied. in hemodialysis patients had an especially high risk for bacteremia, while peritoneal dialysis patients had an especially high risk for peritonitis. Compared with hemodialysis and peritoneal dialysis patients, kidney transplant recipients are at the lowest risk for infection. But the annual percentage of the mortality secondary to sepsis is 20-fold higher in the kidney transplant recipients than in the general population. This study concluded that reduced estimated GFR and albuminuria are associated with increased risk for infection-related mortality. Demographic characteristics as elderly patients and comorbid conditions as diabetes, causes of kidney disease as nephrotic syndrome and selected therapy, especially immunosuppressive, particularly cytotoxic drugs, alteration in immune system, dialysis access, excess health care unit, and finally hyperresponsiveness to vaccine, especially hepatitis B vaccine and influenza vaccine. All of them are potential risk factors to infection. What is the outcome of infection? Hospitalization or prolonged stay in the hospital and infection-related deaths. There are many patterns of infection, such as cardiovascular infection, peritonitis, urinary tract infection, pulmonary infection, mucocutaneous infection, and GIT infection. About cardiovascular infection, infection of vascular access is a frequent and often overlooked cause of inflammation in hemodialysis patients. Moreover, exercise involving foreign materials are especially liable to infection, and they may be a source of bacteremia. Also, chronic hemodialysis is a risk factor for the development of infective endocarditis, and the mortality rates for infective endocarditis in the hemodialysis population are high. About peritonitis, this study shows that peritonitis is significantly associated with mortality in peritoneal dialysis patients. Urinary tract infections are common in end-stage renal disease patients. With reduced urine volume, we could predict that the impaired physical barrier against invading pathogens in these patients might result in inflammation, contributing to a further loss of residual renal function. Pulmonary infection. Pneumonia is a common condition in patients with CKD. Compared with the non-CKD population, the rates of pneumonia are 3 times greater in the CKD population and 5 times greater in the dialysis population. Moreover, the length of hospital stays for pneumonia in CKD and dialysis population are very similar and 4 to 6 times longer than those in non-CKD population. In addition to pneumonia, patients with CKD and on dialysis have a higher risk for TB compared with general population. Also increases susceptibility to fungal and viral infection. Mucocutaneous infection, periodontal disease is more prevalent and severe in CKD patients as compared to the general population. The disease is particularly advanced in maintenance hemodialysis patients and appears to be less severe in peritoneal dialysis patients and moderate in pre-dialysis CKD. Lastly, GIT infection. The intestinal bacterial microflora are a potential source of chronic inflammation in patients with CKD. Uremic patients show elevated counts of both aerobic and anaerobic organisms in the duodenum and the jejunum, which are sites with very low or no intestinal bacterial counts in healthy subjects. Finally, therapeutic and prevention strategies of immune disorders. So management plan for CKD is very essential, starting from screening for CKD risk factors to proper diagnosis and the treatment of the conditions and estimated progression and replacement by dialysis and transplant. Therapeutic and preventive strategy in hemodialysis patients consists of minimized caster use of ultra-pure water and biocompatible membranes, On the other hand, in peritoneal dialysis patients, by preventing peritonitis and use of biocompatible solutions. There are other therapeutic and prevention strategies as preserving residual renal function by controlling of hypertension and controlling of hyperglycemic state and hyperlipidemic state, and achieving normovolemia. Diagnosis and treating asymptomatic infections as chlamydia pneumonia and H. pylori, and use of anti-inflammatory drugs as ACE inhibitor, ARBs, and statins. Thank you.
She will state about anemia in pre-dialysis end-stage renal disease patient. I would ask Dr. Dalia to introduce herself in 2 lines, please, because we have no data about her, and I'm sorry for that.
Bismillah ar-Rahman ar-Rahim. I am Dr. Dalia Musa, specialist of nephrology. Alexandria University.
معايا يعني في اسكندريه.
Anemia in pre-dialysis end-stage renal disease patients. Definition of anemia of chronic kidney disease: hemoglobin level less than 13 gram per dl for adult men and post-menopausal women, and hemoglobin less than 12 gram per dl for pre-menopausal women. Prevalence of anemia in CKD patient: 28% in stage 2 CKD, 87% in stage 4 CKD. Impact of anemia in CKD patient: fatigue, dizziness, shortness of breath, LVH and congestive heart failure, reduced cognitive function and mental acuity, impaired quality of life, need for blood transfusion. For every 1 gram decrease in hemoglobin, there is 6% increase in the risk of LVH and 46% increase in the risk of left ventricular dilatation. Risk factor contributing to anemia in patients with end-stage renal disease: inadequate production of erythropoietin in response to hypoxia is the primary cause of anemia in CKD patient, followed by iron deficiency, whether absolute or functional, gastrointestinal blood loss and blood loss during the dialysis procedure, inflammatory syndromes, hyperparathyroidism, aluminum intoxication, drugs as ACE inhibitors, hemolysis, hemoglobinopathy, vitamin B12 and folic acid deficiency, multiple myeloma and pure red cell aplasia. Total body iron is about 3.5 gram, 65% present within the RBC's hemoglobin, 10% in the muscle fibers and other tissues. The remaining body iron is stored in liver, macrophage, oval RES, bone marrow. When iron gets absorbed from the intestinal lumen, it is carried upon the apotransferrin within the blood to the erythroid progenitors in the bone marrow to form RBCs. When the RBCs get senescent, it gets inside the macrophage where it breaks down and iron used again and recycled again. Forms of iron deficiency: absolute iron deficiency is defined as ferritin values less than 200 nanogram per milli for hemodialysis or less than 100 nanogram per milli for non-dialysis or peritoneal dialysis, with T-state less than 20%. Functional iron deficiency is defined as ferritin values more than 100 nanogram per milli or more than 200 nanogram per milli for hemodialysis with a T-state less than 20%. Causes of absolute iron deficiency: blood loss in dialysis circuit, low-grade gastrointestinal bleeding, frequent blood sampling, multiple vascular access surgeries, decreased oral iron absorption because of dietary restrictions, loss of taste for iron-rich foods. Functional iron deficiency is a failure to release iron rapidly enough to meet the bone marrow demand for RBC's production despite adequate body stores, as in erythropoietin therapy. Reticuloendothelial blockade usually occurs in the setting of acute or chronic inflammation. This often correlates with a high C-reactive protein level or high erythrocyte sedimentation rate. Because of the inflammatory state and likely mediated by hepcidin, the iron that is in RE storage gets locked up there and is not released to transferrin, preventing delivery to erythroid precursors. Indicators of inflammation with subsequent functional iron deficiency are serum ferritin, serum beta-2 microglobulin, serum haptoglobin, CRP. And if it is more than 20 milligram per liter, patient should be screened for silent infection, as in hemodialysis access graft infection, periodontal disease, suboptimal treatment of chronic heart failure, or presence of failed kidney transplant in hemodialysis patient. The most useful tests in assessing the patient iron status are percentage of transferrin saturation, serum ferritin, reticulocytic hemoglobin content, percentage of hypochromic red blood cells, serum soluble transferrin receptor. TSAT measurement can be calculated from two formula, whether the relation of serum iron to TIBC or serum iron to serum transferrin. Beta-2 microglobulin is present on the surface of all human nucleated cells expressing MHC class 1 antigen. Its senses rate range from 2 to 4 milligram per kg per day with a half-life of 2 to 4 hours. Its plasma concentration is 1 to 3 milligram per liter, increases 60-fold in renal failure. It is handled by the kidney. Its value increases 60-fold in end-stage renal disease patient. Its level also increases in lymphoproliferative B-cell disorder, chronic inflammatory states. A relation between lead poison and anemia in end-stage renal disease. Occupational exposure is the main cause of lead poisoning, and lead is a potent inhibitor of gamma-aminolevulinic acid dehydratase, coproporphyrinogen oxidase, and ferrochelatase, enzymes that catalyze second, sixth, and the final steps respectively in the biosynthesis of heme. Anemia may appear at blood lead levels equal or higher than 50 microgram per deciliter and is of hypochromic microcytic type. Lead deposition in the body, mainly in the bone, representing 25%, then the blood representing 2%. Aim of the work: studying some factors other than erythropoietin in induction of anemia in patients with end-stage renal disease. This study was conducted at Nephrology Dialysis and the Transplantation Unit of Alex Main University Hospital. It was conducted in the period from 11/2010 to 4/2011 on 80 pre-dialysis newly diagnosed end-stage patients. Their age 15 to 80 years, mean 53 years, and was compared to 20 healthy controls of security workers whose age 25 to 34 years with mean age 28 years. Exclusion criteria was autoimmune diseases, drugs inducing hemolysis, and industrial workers. After full clinical evaluation, the following investigations were carried, which are routine investigation: iron profile, blood lead, serum haptoglobin, beta-2 microglobulin, and occult blood in stool. Anemia was universal, 100% of our patients. Hemoglobin range 4 to 9.5 gram per GL with the mean 7.4 gram per GL. Microcytic hypochromic anemia was a major type of anemia, 40%, followed by normocytic normochromic representing 33.8%. Occult blood in stool was present in 16 patients, representing 20% of the whole patient group. Combined diabetes and hypertension was present in 40% of studied subjects, followed by hepatitis present in 16.2%. There was a statistical significant difference between the patient and the control as regard both serum transferrin and serum iron, as both were decreased in the patient in comparison to the control. There was a statistical difference between the patient and control as regards serum ferritin, which was much increased in the patient group. No statistical difference was present between the patient and the control as regards TSAT. There was statistical difference between the patient and the control as regards TIBC, which was much decreased in the patient group. Also, there was a statistical difference between the patient and the control as regards serum albumin and serum total protein, which was much decreased in the patient group, while serum haptoglobin was increased in the patient group. There was a statistical difference between the patient and the control also in the uric acid, which was much increased in the patient group in comparison to the control, And also there was statistical difference between them in the blood lead level, which was much increased in the patient in comparison to the control group. Also, there was statistical difference between the patient and the control group as regard each of serum creatinine, beta-2 microglobulin, and blood lead, as each of them was increased in comparison to the control, while serum iron was decreased in the patient group in comparison to the control. As regards the correlation between different measured variables in group 1 alone or group 2 alone and the total studied subject of the study, there was significant positive correlation between each of serum beta-2 microglobulin and serum creatinine, serum beta-2 microglobulin and serum ferritin, TIBC and serum transferrin. Also, significant positive correlation was present between T-sat and serum iron, serum transferrin and serum iron, serum ferritin and serum haptoglobin within group 1 only. Significant negative correlation was present between beta-2 microglobulin and hemoglobin, beta-2 microglobulin and serum iron. Significant negative correlation was present between serum ferritin and measured serum TIBC, serum ferritin and serum transferrin within group 1 only. Laboratory tests for hemolysis were negative, including mean reticulocytic count was less than 2%, mean serum indirect bilirubin and LDH was within normal, negative comb test, negative urinary urobilinogen, serum haptoglobin was not consumed. Patients included in group 1 were further classified into 3 subgroups according to their serum ferritin and T-sat. Absolute iron deficiency subgroup defined as patient with serum ferritin less than 100 and T-sat less than 20%. Functional iron deficiency subgroup defined as patient with serum ferritin more than 100 and T-sat less than 20%. Good iron status subgroup defined as patient with serum ferritin more than 100 and T-sat more than 20%. There was a statistical significant difference between the 3 groups as regards serum transferrin, which was much increased in the absolute iron deficiency group in comparison to functional iron deficiency group and good iron status group. Also, there was statistical difference between the 3 groups as regards serum ferritin and serum iron in absolute iron deficiency group, as both of them was decreased in the absolute iron deficiency group in comparison to the other groups. Conclusions: the majority of studied patients presented by severe anemia which was associated with chronic renal impairment accidentally discovered. The most common morphological feature of anemia was microcytic hypochromic type. We found that occult blood in stool was present in 20% of studied subjects. Low levels of serum albumin and total proteins indicate that patients with end-stage renal disease presented with advanced stage of malnutrition. There was no evidence of hemolysis in the newly diagnosed end-stage renal disease patient. As the mean blood lead level value in the patient group, as the mean blood lead values in the patient group were 50.5 microgram per GL, lead could be a contributing factor for anemia in our patient. Both blood lead and serum uric acid levels in the patient were higher than in the control, although no significant correlation was found between them. Lastly, other risk factors contributing to anemia in Egyptian newly diagnosed end-stage renal disease patients are malnutrition, occult blood in stool, inflammation, and high blood lead levels. Thank you.
Thank you, Dr. Dalia. No, sorry for no time for question, because all of us are hungry.
لا في question بس سؤال بس يا دكتور داليا، حضرتك اعتمدتي على الاوكلت بلاد ستول، يعني هل هو sensitive enough يعني ولا كان يبقى احسن ان احنا عملنا اندوسكوبي؟ يعني انت الاوكلت بلاد ستول دي ادتني ايه؟ فادتني في ايه؟
عشان دي المفروض العيانين اللي طلع عندهم اوكلت بلاد انستول بنعمل لهم بعد كده فيرذر انفستيجيشن باي اندوسكوبي، بس هي رف استيميشن قبل الاندوسكوبي.
الاوكلت بلاد ستول وخدنا بقى كل البريكوشنز بتاعتنا وبطلوا الحاجات كلها
بالظبط.
انا بيتهيألي ان هو ما بيبقاش سنسيتيف قوي، لكن يعني انا بس حبيت هايلايت النقطه دي.
شكرا يا
I know it's time for dinner. I am Dr. Hani Barbari, nephrology lecturer, Nufia University. I will try to be as concise as I can. My topic today is about IgA nephropathy, characterizing the pathogenic IgA phenotype in IgA nephropathy. As you all know, IgA nephropathy is one of the commonest patterns of GN, and is characterized by mesangial deposition of polymeric IgA. IgA deposition is associated with variable degrees of glomerular injury and renal dysfunction, and leads to progressive renal failure in almost 1/3 of cases. So it is not yet considered to be a benign disease as we have been considering it for a long time. But now there is a convincing evidence that almost 1/3 of cases will progress to end-stage renal disease and be maintained on dialysis. There is now convincing evidence that mesangial IgA is derived from a small fraction of the total circulating pool of IgA. This is the IgA molecule. On the left side is the IgA molecule, and this is the hinge region. This region, hinge region, is the area of our interest because it contains amino acid residues. These amino acid residues are potential sites for O-glycosylation. O-glycosylation is the core factor in the pathogenesis of IgA nephropathy. One of the most consistent abnormalities of serum IgA in IgA nephropathy is apparent O-glycosylation. In IgA nephropathy, this apparent O-glycosylation is reduced, leading to increased frequency of truncated O-glycans and enhanced exposure of the terminal gallnet, which makes these molecules of IgA sticky molecules and more liable for mesangial deposition. IgA, which was elevated from the IgA nephropathy glomeruli, is apparently O-glycosylated, as we have just mentioned, and is more abnormal in this regard than serum IgA. That's why we think that some factor other than the blood, the peripheral blood, behind the pathogenesis of IgA nephropathy, and strongly implicating altered glycosylation in the process of IgA deposition. In the absence of GAL, the terminal sugars are recognized as epitopes, so it will be considered as antigenic structures and mediate immune response and form immune complexes and deposited in the mesangium of the kidney. However, up till now, the pathogenesis of IgA nephropathy is still obscure, still not clear, and the functional effects of altered IgA1 hinge region, as you have just seen, O-glycosylation still imprecisely understood, because we don't know why this O-glycosylation is reduced, and we don't know why it's defective, and we don't know why this under-glycosylation or defective glycosylation leads to more deposition of IgA in the mesangium of the kidney. So where is the pathology in IgA nephropathy? Is it in the kidney, in the mesangium of the kidney, which makes these molecules more liable for deposition in the mesangium? Is it in the matrix components? Or is it in the blood, in the peripheral blood mononuclear cells, which makes defective forms of IgA1, which is deposited in the mesangium of the kidney? Or is it in the bone marrow, which forms the B cells and form the plasma cells and form the IgA molecules? Or is it in the IgA molecule itself? The overall aims of this study were to characterize the pathogenic IgA phenotype, the physical-chemical characters, and the conformational changes of the molecule that makes this molecule sticky and deposited in the mesangium of the kidney, and starting the pathological process of renal injury, inflammation, and then fibrosis and renal scarring. This was done by investigating the following hypotheses. The first one was whether the fundamental pathogenesis of IgA nephropathy lies in the bone marrow cells. And the second one is IgA1 under-glycosylation IgA nephropathy patients is due to either dysregulated expression of the enzymes of O-glycosylation, which are C1 beta 3 glycosyltransferase, GalNAc, and cosmic, relative to IgA expression, or dysregulated expression of the chaperone protein cosmic relative to the C1 beta 3 glycosyltransferase. These are the O-glycosylation enzymes responsible for glycosylation of the hinge region of the IgA1 molecule. These were investigated using real-time PCR to compare the mRNA expression of different O-glycosylation enzymes in peripheral blood mononuclear cells, B cells, and in bone marrow cells in IgA nephropathy patients and the controls. The study was approved, of course, by the Research and Ethics Committee, and all subjects given written informed consent to their participation in the study. For the peripheral blood mononuclear cells, we isolate the cells from peripheral blood, and the cells were lysed, and then we extract mRNA and cDNA and expose the cells to mitogen stimulation, antigenic stimulation. One of them is non-specific, which is the buckwheat mitogen. One of them is specific for B cells, which is the tetanus toxoid detox, and one of them is specific for T cells, which is the flu vaccine. Peripheral blood mononuclear cells were taken from 12 patients, 12 controls, of course, age and sex matched. The cells were isolated, cultured, and suspended lysis buffer. For the bone marrow samples from IgA nephropathy patients and the controls, bone marrow samples taken from 13 IgA nephropathy patients, 12 controls, age and sex matched, kept in sterile tubes and stored in liquid nitrogen, and we extract mRNA and cDNA from the samples by reverse transcriptase system. Conventional PCR was done just to check the primers. The primers were specific for the sequence, and then real-time PCR was done to check the mRNA expression of the different genes of the enzymes responsible for the O-glycosylation. Our results, this table shows the different mean ratio values of O-glycosylation enzyme expression for peripheral blood mononuclear cells of IgA nephropathy patients and controls. It shows that cosmic to IgA1 ratio value was significant between patients and the controls. This graph shows the expression of mRNA for O-glycosylating enzymes in IgA nephropathy patients and controls after 3 days of buckwheat mitogen stimulation, which stimulate non-specifically both T cells and B cells. We found high significant difference between patients and the controls in beta-1,3 galactosyltransferase to cosmic and the GalNAc to cosmic, respectively. This graph is very important because it shows the mRNA expression of the bone marrow cells. This graph showing comparison of means of O-glycosylation enzyme different ratio values of bone marrow samples in IgA nephropathy patients and controls. We found no significant difference between patients and the controls. And this was out of our expectations because we put a lot of hope on the role of bone marrow in the pathogenesis of IgA nephropathy. This graph showing means of glycosylation enzymes in IgA patients and the controls. After 2 weeks of buckwheat mitogen, there was significant difference in IgA1 mRNA expression. This table shows the mean values of O-glycosylation for peripheral blood mononuclear cells of IgA nephropathy patients and the controls after 2 weeks of tetanus toxoid stimulation, which can stimulate specifically the B cells. We found significant difference in the ratios of GalNAc, beta-1,3 galactosyltransferase, and the IgA1. This graph showing means of O-glycosylation enzymes ratios for peripheral blood mononuclear cells of IgA nephropathy patients and the controls after 2 weeks of flu vaccine, which stimulate T cells. We found no significant difference between patients and the controls, which highlight that the role of T cells in the pathogenesis of IgA nephropathy is not that much as we expect. This graph is very important because it shows the correlation between O-glycosylation activity in B cells from peripheral blood and bone marrow. There was, as you see, a significant positive correlation between the activity of the enzyme in bone marrow cells and the peripheral blood cells. This graph showing a correlation between serum IgA activity, glycosylation, and the enzyme activity in IgA nephropathy patients and controls. A and B, these are IgA nephropathy patients. C and D, these are the controls. The first one, A, we found no correlation between the peripheral blood and the lectin binding of the O-glycosylation activity of the enzyme activity. The idea behind lectin binding is that IgA molecule is dependent on the Mannan binding lectin pathway of complement. It's not depending on the classical pathway of complement activation, and its role in the alternative pathway is controversial. So this molecule is dependent on the Mannan lectin binding pathway for its immune response. For the bone marrow cells, we found a positive correlation between the enzyme activity and the lectin binding, And for the controls, we found inverse correlation between the peripheral blood enzyme activity and directed binding, which was expected. Because when directed binding is increased, this means that these molecules are sticky and immunogenic and started the pathogenesis and the pathology of IgA nephropathy. This graph is very important. All these graphs, A, B, C, D, are for IgA nephropathy patients. We're comparing the activity of the enzyme to the mRNA expression. The mRNA expression was highlighted by CT. CT value means cycle threshold of the expression. We found strong positive inverse correlation between the enzyme activity and the CT value, because when the CT is decreased, this means that the mRNA expression is increased, and that means that the activity of the enzyme is increased, which was expected, and they give more weight to the results of our experiment. We found, this is our conclusion, we found no differences between IgA nephropathy patients and controls in the levels of B cell, C1, beta 1,3 glycosyltransferase activity or expression of any of the genes in bone marrow samples. And as I have just mentioned, this was out of our expectations because we put a lot of hope on the role of bone marrow in the pathogenesis of IgA nephropathy. Our results demonstrated that there is indeed an imbalance between cosmic and C1 beta 1,3 glycosyltransferase mRNA levels in peripheral blood mononuclear cells stimulated with buckwheat mitogen and in IgA nephropathy patients. This most likely represented a relative underexpression of cosmic, and this is very important because it can highlight for the first time why IgA nephropathy is more common in males more than females, because the expression of this gene is found on the chromosome X, which is, as we all know, females have two X chromosomes and the males have only one. Our results showed that cosmic expression level was found to be significantly decreased in peripheral B lymphocytes, and just 1 minute, of IgA nephropathy patients, which is also negatively correlated with IgA glycosylation degree. Our results show that there was an imbalance in IgA nephropathy patients compared to controls in IgA1 mRNA expression following exposure to antigenic stimulation for 2 weeks by buckwheat mitogen and the tetanus toxoid. Future work should focus on the factors controlling the profile of IgA1 glycosylation in different immunological situations and other diseases such as hemophilia purpura. Our study investigated the mRNA expression indirectly in the lysates of cells, but to give more clinical application to the test, we should examine this mRNA expression directly by other means and other factors like mass spectroscopy. In future studies, in order to obtain a clear picture of C1 beta 1,3 glycosyltransferase and the H-chaperone protein, the degree of decreased expression should be determined because we don't know how much reduction happened. We know that there is reduction, there is defect, but we don't know how much defect, how much reduction happened in these patients. To confirm that our finding has pathological importance, changes in mRNA expression must be correlated to changes to functional serum protein products, because it is not a must if there is reduction in the mRNA expression to have a reduction in the protein synthesis, because not all parts of the genes are functional parts, and we don't have that housekeeping ideal gene for our experiment. The decrease in C1 beta 1,3 GALT and the cosmic gene expression levels needs to be correlated to the severity of proteinuria to have clinical application on the patients, which may suggest a potential prognostic property. Thank you.
شكرا. في حاجة تانية ولا خلاص على السيشن ده؟ دلوقتي هنقفل السيشن ده عشان تروحوا تتعشوا إن شاء الله.
As regard the routine energy wasting correlation with the autoimmune system in industry-driven disease and its impact on the cardiovascular morbidity and mortality, especially in the